Hi, I'm Joe Graydon.
I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy, where we bring you the stories behind the health headlines.
This podcast is brought to you by Redix Industries, makers of Utterly Smooth Body Cream. 800-345-7339, on the web at uttercream.com. Doctors and patients speak different languages. Medical slang and technical terminology create barriers to clear communication. This is the People's Pharmacy with Terry and Joe Graydon.
Dr. Brian Goldman is an emergency physician and outspoken medical journalist who reveals the secret slang of doctors. Why do physicians and medical students invent new terms as soon as the old ones become widely known?
People using this slang are part of an in-group. But does this jargon have disadvantages? Is patient safety compromised when communication is confusing?
Have you ever wondered what your doctor was writing in your medical chart? New research shows open notes can help patients engage in their own care.
Coming up on the People's Pharmacy, cracking the code of hospital slang.
First, this news.
In the People's Pharmacy health headlines, aspirin can help prevent colon cancer, according to a report in the Annals of Internal Medicine. A study of more than 112,000 Danes took advantage of excellent medical records that carefully track medication use. In Denmark, doctors prescribe most of the aspirin that's taken, as well as other nonsteroidal anti-inflammatory drugs such as ibuprofen. The prescription histories of approximately 10,000 people with colon cancer were compared to those of 100,000 individuals without colon cancer. Those who had taken low-dose aspirin, 75 to 150 milligrams a day, continuously for 5 years or longer, were 27% less likely to have colon cancer than those who didn't take aspirin or took it only sporadically. People who had taken non-aspirin pain relievers regularly were also less likely to have colon cancer. That association was strongest for COX-2 inhibitors such as celecoxib, taken for years at a relatively high dose. People on that regimen were more than 40% less likely to have colon cancer. This is just the latest research to show that aspirin can reduce the risk of developing colorectal cancer. Both aspirin and other NSAIDs have the potential to cause serious side effects such as bleeding ulcers. So most experts recommend that people who would like to take one of these for cancer prevention should check with their health care provider first.
New data published in JAMA Oncology raise questions about the best way to treat a breast condition called ductal carcinoma in situ, or DCIS. About 60,000 women in the U.S. are diagnosed each year on the basis of mammography. DCIS is sometimes referred to as stage 0 breast cancer, but there's debate about whether these abnormal cells lining a milk duct in the breast should be considered cancer at all. The research used 20 years of follow-up data on more than 100,000 women diagnosed with DCIS between 1988 and 2011. Many of these women had been treated with lumpectomies. Others got mastectomies or radiation. The method of treatment did not make any difference in the likelihood that a woman diagnosed with DCIS would later die of breast cancer. Just over 3% of the women had died of breast cancer after 20 years, regardless of treatment. Women under 35 at the age of diagnosis with DCIS were 17 times more likely than women without such a diagnosis to die of breast cancer within 10 years. African American women were also more than twice as likely to die of breast cancer after a diagnosis of DCIS than women in the general population. Studies are needed to determine if treatment can lower breast cancer mortality rates in women diagnosed with DCIS.
Can older people keep their brains sharp as they age? 2 studies published in the Journal of the American Medical Association are disappointing. Neither regular exercise among previously sedentary elders nor fish oil supplements rich in omega-3 fats were able to improve or preserve cognitive function. The first study, titled Lifestyle Interventions and Independence for Elders, assigned more than 1,600 sedentary older adults to moderate intensity physical exercise or health education and arm stretches. Cognitive function was tested at the beginning and end of the intervention, which lasted 2 years. There were 2 group sessions per week, with encouragement to do the exercises at home 3 or 4 times in addition. The participants attended almost 3/4 of their sessions. There were no significant differences overall, but people over 80 who started with poor fitness improved in measures of executive function if they were in the exercise group.
Taking pills may be easier than exercising, and previous studies have suggested that people who eat diets rich in omega-3 fats from fish or nuts are more likely to retain their cognitive abilities. Cognitive testing was included as part of a trial primarily designed to see whether fish oil, together with other supplemental nutrients, can slow the development of macular degeneration. This part of the AREDS-2 trial included more than 3,500 older people who were randomly assigned to fish oil or placebo supplements. The study lasted nearly 6 years. Cognitive changes during that time did not differ between the groups. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. Miscommunication between physicians and patients is far too common. That's because they speak different languages. Doctors love Latin. And they also have their own kinds of slang that are specific to healthcare situations. Have you ever tried to make sense of big words like renal insufficiency or cardiac ejection fraction? Why can't doctors speak in plain English instead of medical jargon?
To help us understand doctors speak, we turn to Dr. Brian Goldman, an emergency physician at Mount Sinai Hospital in Toronto. He's host of the radio show White Coat, Black Art on CBC Radio 1. He's an outspoken medical journalist whose previous book was The Night Shift, Real Life in the Heart of the ER. His new book is The Secret Language of Doctors, Cracking the Code of Hospital Slang.
Welcome to the People's Pharmacy, Dr. Brian Goldman.
I am so pleased to be with you again, Joe and Terry.
Well, we are delighted to have you with us. We are especially interested in today's topic because, you know, all professionals have shorthand or jargon to make communication quicker. I don't care whether it's computer programmers, mechanics, plumbers, lawyers, they all have shorthand. But doctors and other healthcare professionals, golly, they seem to have more acronyms and code words than just about anybody else. You know, people have learned what code blue stands for, but they don't understand a lot of the rest of it. And you know what? You guys still use Latin. I can't believe it. It's a dead language. So tell us, why is this secret language useful?
The secret language of doctors is, and other health professionals, because I have heard paramedic slang, I've heard nursing slang, I've heard social work slang, and most of our allied health professional friends use slang. It's useful for a whole bunch of reasons. You started to talk about the first bit, and that is that you can pack a lot of information into a small number of words. You know, I can say that a patient is at or near the end of life, and we've turned a corner and we understand that we're no longer providing active treatment and we're moving to comfort measures, and the family knows. So if one junior resident says it to another in the middle of the night, if you hear that the patient's blood pressure's dropped or that they've spiked a temperature, you can walk to the bedside. You don't have to run to the bedside. Well, you can say all of that in 3 words, circling the drain. If you say the patient circling the drain, all of that is understood by when at handover, when one member of the house staff, when one resident is explaining it to another. So you can economize, and not only can you provide the information that's clinical, you can also add the emotional tone, which of course we have, even though they say that physicians are supposed to keep their emotions in check. We all know that we're not Vulcans, that we have emotions and that they need an outlet. And I would rather that people use slang, provided it's not pejorative, than go home and drink alcohol to try to soothe their sorrow. So one important reason for slang is the economy of language. But there clearly are other reasons. It reinforces the bond between my team, my group, myself, and the other. And the self can be emergency physicians inventing slang about colleagues, about psychiatrists. It could be surgeons inventing slang about anesthesiologists, anesthesiologists inventing slang about surgeons. It can also be, unfortunately, all too often, physicians and other allied health professionals inventing slang about patients. And also, there is slang that we invent to describe situations that are emotionally charged or sometimes, frankly, disgusting, dealing with poop, dealing with human poop. There's a lot of people who have no idea that when they become a physician or a nurse, that they're going to have to deal with human poop. And so they invent a slang for it, and that's a way of dealing with their feelings.
Hence the term code brown.
Code brown. It's a lovely phrase because it is the essence of hospital slang, or argot. Argot comes from les argotiers, a group of robbers and thieves circa 1628 who invented a slang that they could speak around their potential crime victims without their victims being the wiser. So the beauty of Code Brown is that it's a neutral phrase that means nothing to bystanders, unless you read the book, of course, and everything to the people who know what it means. So Code Brown, of course, is a poop emergency. And it speaks to so many different parts of the culture of medicine. Terry, I know you're a medical anthropologist. So you're going to love this. Code Brown stories are told by the people who have had to clean up the Code Browns. And so that takes you to kind of a sociological examination of who does what in the hospital. And you wouldn't be surprised if I told you that nurses have far more Code Brown stories than doctors, because it's the nurses who clean it up, and it's the licensed practical nurses, a rung below the registered nurses and the nurse practitioners who have more of the Code Brown stories than the senior nurses, or the nursing leaders, the nursing unit administrator, the head nurse, if you want to.
Well, because they have all the experience, or a lot of it.
Yeah, and there was a serious side to my book. This is not a joke book. It's not a book of urban medical slang. Why do we care about Code Brown? Well, for a couple of reasons. First of all, let's take us back to the patient. There's nothing more dehumanizing than losing control of your bowels. There's nothing more abject. And very often, health professionals tell these stories without thinking of the extreme mortification that patients feel when it happens. I don't think anybody wants it to happen. They're embarrassed. They're shamed. And I think we need to be more mindful of that. The other thing that's very important to the Code Brown story is that who cleans up the Code Brown is really important to the safety of a hospital, because we have hospital-acquired infections, and with the downloading of responsibility for maintenance and for cleaning, disinfecting the hospital, we have every reason to be concerned that if somebody doesn't clean up a Code Brown properly, that you might end up carrying hospital-acquired infections from one ward to another.
Well, exactly. As a matter of fact, the janitorial staff is a critical part of infection control, although they may often be treated just like janitors.
Yes, exactly. And one of the things that I've learned over the years, working night shifts, working day shifts, is that the hospital functions because of every great person who works in the hospital, just as every patient has a story to tell. And when we stereotype and dehumanize patients, we're taking away their humanity. And I think that's one of the great ethical lapses of medicine.
Well, that's probably one of the risks of the type of shorthand language that you're talking about. One of the things that we know from an anthropological perspective is that this kind of in-group special slang really sort of signifies who's in the in-group and who's not. And since patients are definitively not in the in-group, this may mean that they get kind of objectified, doesn't it?
absolutely correct. And there are many manifestations of that objectification. And there are egregious examples of slang, and there are more benign ones that are equally telling. And I was spare with the use of slang in the book. I deliberately decided not to publish hundreds and hundreds and hundreds of synonyms, but to pick a few archetypes and then analyze what do they mean. So let me take one in particular because it's benign. It can be said in mixed company. It's ironic. It exemplifies a lot of the elements of slang that I discovered. Here's the phrase, frequent flyer. It refers to patients who present to the emergency department, typically because that's the doorway, that's their entry point to the emergency department many times. And often they're known on a first-name basis. We're talking about people who may come to the ER 200, even 300 times in a 4-year period. And there is a tendency among emergency staff to, not all of them, but some of them, to refer to such patients as frequent flyers. Now, it sounds like benign or neutral slang, but the problem with it is that, first of all, it's ironic. In the airline industry, a frequent flyer is a beloved customer, but in a publicly funded, in a Medicare environment, in a publicly funded healthcare system such as we have in Canada, a frequent flyer is a nuisance. And there's so many psychological reasons why health professionals greet the patient who comes back again and again with antipathy. They might be thinking, are they scamming us for drugs? Or do they want booties or a taxi chit or a meal or a place to stay tonight? All of the above may actually be true, but we don't have to blame them for it. Or on a deeper psychological level, you again. A patient comes back, what am I going to think? Oh, I failed them. And if I failed them, do I really want to see them again? And so you hear sometimes, I don't have anything more than I can offer this patient, and yet here they are. So that's the way they get treated when it's all in a name. Jeff Brenner, who is a public health specialist of some great renown in Camden, New Jersey, he has coined the term super users or super utilizers to refer to them. And I like that because that's jargon. It takes it away from the character. When you call somebody a frequent flyer, you may be referring to the person, whereas super utilizer refers to what's happening, that they're coming back. And he has done more than almost anybody in the United States to figure out why they come back. And they come back often because they never received their prescription, or there may have been a language barrier, or, they didn't know how to take their prescriptions. They didn't know how to modify their risk factors for a stroke or a heart attack. And when you address those factors in the ways that he's done, and I describe it in my book, guess what? They stop coming to the ER because they're taking better care of themselves.
You're listening to Dr. Brian Goldman. He's an emergency room physician at Mount Sinai Hospital in Toronto, Ontario. He also hosts a popular radio show about the practice of medicine called White Coat, Black Art. It airs on CBC Radio 1. His most recent book is The Secret Language of Doctors, Cracking the Code of Hospital Slang.
A recent study in the journal Clinical Pediatrics illustrates how misunderstanding can occur because of confusing language. The researchers discovered that when pediatricians use the term pink eye, they confuse parents. Although physicians realize this is a symptom that might have any number of causes, parents understand it as a serious infection that probably needs to be treated with antibiotics.
When pediatricians in the study used the term pink eye, parents wanted antibiotics, even if the doctor said that antibiotics wouldn't work. That's the case when the symptoms are caused by a viral infection, a common cause of conjunctivitis.
We need to take a short break. When we come back, we continue our discussion with Dr. Brian Goldman to learn about the downsides of medical jargon.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you value the health information you get when you listen to The People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com.
Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is made possible in part by Red-X Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. The number's 800-345-7339, online at uttercream.com.
If you'd like to order a CD of this show, you can call 800-732-2334. This is show number 1004. That number again, 800-732-2334. Or you can place the order online at peoplespharmacy.com.
Today we're talking about the inscrutable language doctors use among themselves. Sometimes doctors get themselves into trouble when they think patients can't hear them. A judge recently awarded a patient $500,000 when the anesthesiologist made disparaging remarks about annoying patients during a colonoscopy.
Our guest is Dr. Brian Goldman, an emergency physician at Mount Sinai Hospital in Toronto. He's host of the radio show White Coat, Black Art on CBC Radio 1. He's an outspoken medical journalist whose previous book was The Night Shift, Real Life in the Heart of the ER. His new book is The Secret Language of Doctors, Cracking the Code of Hospital Slang.
Dr. Goldman, you've been talking about the value of this shorthand language, but maybe there are some downsides. Let's talk a little bit about DNR. I mean, that's a pretty sensitive topic. And as an emergency physician, sometimes you're faced with a very serious complication and you have to talk to family.
And the first thing to do is to explain what Joe meant by that acronym DNR.
Yes, DNR is actually becoming increasingly passé or outdated, but it's in the lingo and we have to talk about it. And that's interesting because once slang enters public vernacular, it's very hard to, you could call it slang. But there is a whole lore behind this. DNR stands for Do Not Resuscitate, and it goes back to the Supreme Court case of Karen Ann Quinlan. You may remember she was a young woman who took an overdose of alcohol and drugs, and she went into a coma. She was resuscitated, placed on a ventilator, and in fact her parents wanted the ventilator to be turned off so that she could be allowed a natural death. And the doctors fought that, and eventually the case went to the Supreme Court of the United States, and the court ruled that the families, the next of kin, the substitute decision makers have a right to weigh in on the decision of whether or not to withdraw care. The upshot of that was that from that point onward, if in the hospital, if a patient suffered a cardiorespiratory arrest, their heart stopped, they stopped breathing, the default option that doctors and nurses and other healthcare providers had to provide for the patient was a full-on resuscitation. Compressions, chest compressions, defibrillation, the whole 9 yards, unless you could get the patient to sign do not resuscitate form, or, of course, their substitute decision maker if they were in a coma, if they had dementia, and there were cognitive issues. So what you have, to get back to your point, Joe, in the emergency department, you have a patient who arrives in the emergency department severely short of breath, and you can see the handwritings on the wall that they may stop breathing. So we have these often very quick conversations, sometimes in a hallway, where it's a 1-2 punch. And I say a punch because the first punch is a punch to the gut. You're telling substitute decision makers, loved ones, family members, that their loved one is not doing well. And what do you think they would want if their heart were to stop? And very quickly, so this is often shocking news. My father passed away at 92, and I can tell you, I know all the ins and outs, and it was a hard moment for me to have that conversation with the medical staff. But you have that conversation, and then often a minute or two later, oh, by the way, it's not likely that much good would come from a resuscitation. Would you like to sign a DNR? And families are often discombobulated at that point. They're shocked. And so these conversations often very quickly go off the rails, or patients or substitute decision makers sign them and really don't understand what they've signed or why they've signed them. Now, we've changed the language. We're starting to call it do not attempt resuscitation. Why? Because very often for the majority of patients that we see coming to the emergency department at or near the end of life, resuscitation is futile. And that's another important undercurrent of the book, that futility, medical futility, is something that is aggrieving and exercising the health professions right now. They are increasingly upset emotionally. It's morally distressing to try to resuscitate somebody knowing that all you're going to do is crack ribs and suffer on the patient what you believe to be an indignity on the body. And you want to be able to do anything to avoid it. And so sometimes you actually put pressure on the family, and, people can't help themselves. There's time pressure. What I've done is I've completely changed my practice. I will have it as a single conversation. I fear that your loved one, your dad, your mom, may not make it this time. And I let that settle with the family, and I'll come back later or wait for another morning to have that second conversation about signing a DNR form.
Tell us about Code Blue, Hollywood Code, Show Code, and Light Blue.
So Code Blue is the full-on cardiac arrest procedure that we are obliged to do ethically and legally unless the patient or the substitute decision maker signs a DNR. Everybody knows what that means. Code Blue was invented as neutral language that could be said over a hospital intercom without upsetting anybody. Of course, everybody knows what Code Blue is now because it's been on Scrubs and it's been on Grey's and all the other medical shows. So that's CPR, that is intubation, putting the patient on a ventilator, all the cardiac drugs, defibrillation, etc. So slow code is all of that, except that you don't run to the cardiac arrest, you walk. You're slow to order medications, you're slow to defibrillate, and it's done often without anybody saying this is a slow code. There's kind of nudges and winks. Everybody's looking at each other, and they understand that what they're trying to do is stall for time until it is clear and obvious that the patient has died and is irretrievably dead beyond resuscitation so that they can pronounce the patient deceased. This is a clandestine, unethical practice for which we have no statistics, but for which we know it happens, and it probably happens all the time. Call it a passive-aggressive approach to a family who may be reluctant to sign the DNR because they equate signing a do not resuscitate or do not attempt resuscitation with playing God. And they don't want to play God, and who wants to play God? If I've had that conversation once, I've had it 1,000 times with middle-aged, 50, 60-something children who, when you look at them about signing a DNR, they say, we'll put it in God's hands, or they'll say, we'll cross that bridge when we get there. And, I'm thinking that bridge was 20 miles ago. But, and there we are. So slow code is doing it slower. Show code is slang for doing a cardiac arrest in front of a family so that it looks like you're doing it, but you're not doing it to the same intensity that you would do it if you were trying really hard to save a life. Light blue code is a synonym, so they're all synonyms. Light blue meaning it's a lesser version of a Code Blue.
And it sounds like Hollywood Code might be almost the same as a show code.
Yeah, I think it is. I think it is exactly. But, I'm going to also say that there may be another definition for a Hollywood code. And that has to do with a very distressing account by a pediatric intensivist. It was published in the New England Journal of Medicine. This is a bioethicist from Boston Children's Hospital, who is also an intensive care specialist. And he told a dreadful story of a child who was born with a congenital condition and reached the end of life, was in the intensive care unit, and all agreed that he was not going to live a normal life and was probably going to die a natural death very quickly. But what the team did was a full-on cardiac arrest procedure, Code Blue procedure, did everything. And the intensivist quoted two people. He quoted a nurse who said that she had to leave the room because she wanted to throw up. It was that egregious to her, this indignity that was being committed on this poor child. But he also quoted the father of the child who said, when I saw the detritus of failed attempts at putting central lines in, all the catheters and all the needles strewn about, he said, quote unquote, I knew that the doctors did everything they could. And to me, that's a Hollywood code. And it's as unethical to do more than you should be doing when it's futile as it is to promise that you're going to do a full-on cardiac arrest procedure, Code Blue, and then not do it.
Dr. Goldman, you've been talking about the benefits of the secret language of doctors, and I can understand why the shortcuts and the slang and the argot is all valuable, but there may be a downside for patients. And I go to the Hippocratic Oath, which, again, has been translated in all kinds of different ways. But here's one translation that says, I will impart a knowledge of the art, meaning the art of medicine, to my own sons and those of my teachers and to disciples bound by a stipulation and oath according to the law of medicine, but to none others. And so this is that historical perspective of that language of Latin, where you use terms like myocardial infarction, which of course gets shortened to MI instead of heart attack. Now that's now, as you say, in the popular language, so patients understand when they hear myocardial infarction or MI.
Well, Joe, actually, when you're talking about the Hippocratic Oath, you're really talking about ancient Greek rather than Latin.
True enough. But the point is that, a lot of this secret language was to keep patients in the dark.
Yes, what an interesting point. It's a wonderful question. My answer to that is that I think times are changing. I think we live in an era where there's democratization of information. People can Google, they can search as well as I can. I hope that my study of metacognition and search terms makes me better at parsing out the words that I think will get better hits. I know the difference between high quality and poor quality websites. But that said, we live in an era in which there are health apps where people can measure their own oxygen saturation. Heck, they can do their own electrocardiogram. We have an individual who asked. This is Hugh Campos, who had an implantable cardioverter defibrillator. This is a device that would sense when his heart rhythm went into ventricular fibrillation or ventricular tachycardia, and he would do his own code blue. In other words, this device would shock him back into normal sinus rhythm, and he discovered that this machine is not only sensing his heart rhythm but recording it. And he asked the company for the data, and he sued until he got the data, and he learned something very interesting when he analyzed it. He discovered, because, this is a life-saving machine, but if you can avoid having those shocks, well, who wouldn't want to avoid them? They're pretty upsetting. Imagine a jolt of electricity going through your body. Yes, it's life-saving, but it's pretty shocking if I can use the pun. Well, he discovered that when he drank one particular kind of alcohol, he would be more likely to have a bout of ventricular tachycardia or fibrillation, and it turned out to be Scotch. And once he learned that, because he was able to keep a diary, and that coincided with the periods of time when his heart went into ventricular tachycardia or ventricular fibrillation. The bottom line is that he stopped drinking Scotch. Poor him. I love Scotch, but he stopped having episodes. And we are living in an era now where more and more people, not everybody, but more and more people want their own data, want to know what the terms mean. And that's why I wrote the book, to level that playing field so that people understand not only the words, but the feelings and the kind of cultural interpretation of the words, so that they can understand the frustrations that health professionals are feeling, not necessarily about patients, but maybe lack of equipment, lack of proper systems to look after them, lack of training, and that those need to be addressed. And sometimes the public can be in the perfect position to say, we agree. For instance, if we have an epidemic of people who have dangerous obesity, bariatric patients, people with a body mass index over 45 or so, or 40 to 45, we need to have stretchers that can take their weight. We need to have wheelchairs that can take their weight, operating room stretchers that can take their weight, and we need to have surgeons who are skilled in operating on them, and obstetricians who can do cesarean sections on people who weigh 500 or 600 pounds, and not simply, tusk people and say, you've got to learn how to lose weight. And we need to have respect for people who have lost more weight than you and I combined, and fight that good fight every day to get out of bed when you weigh 500 or 600 pounds, because it is very difficult and requires a great deal of stamina to do so.
Yes. Now, Dr. Goldman, I want to go back to this idea for a moment of this secret language, because I understand the value and the shortcuts and the insider stuff. But why do doctors still have to use the word renal when kidney works just as fast, just as well, or hepatic versus liver, again, just as quick. And then there's cephalalgia versus headache. I mean, come on already. Why can't we just use normal language?
Well, Joe, I agree with you 100%. And part of that democratization means being clear in communication. I host a radio show where I unpack secret language all the time and explain things like that. You know, I think that language, special language, technical language is useful in medicine as it's useful in among air traffic controllers, people who run nuclear power plants, and all kinds of high-intensity environments if they have to learn and master a lot of concepts, and if the language allows them to say things economically and everybody understands what they mean, and that means they can communicate a situation quicker. That could be very important when life, when seconds count, when lives are on the line. However, what you're speaking to is the place where the economization and the need for economy gives rise to a kind of an egotistical need to name things. And we play games with each other in the culture of medicine. You know, Terry, you could do an anthropological study of how we test each other to see if we know the latest language. For instance, I'll give you an example. Somebody refers to a T-max. And a resident is describing a patient to me and they're saying T-max normal. So that's a breadcrumb that's been thrown to me. We're going to see if Dr. Goldman knows that T-max means what's the patient's maximum temperature. It's a fancy way of saying have they had a fever. And so, you learn something about a person if they have to say, I'm sorry, can you explain what that means to me? Another one that we've heard recently are B-cell symptoms. So that's become short form for fever, night sweats, chills, itchy skin. They're signs of a B-cell lymphoma. And so we tend to jargonize and invent jargon on the fly. This has a serious side, Joe, because if you fail to communicate when seconds count, patients can die. And we have in healthcare a culture of hinting. We hint to people because we want to see, are you as smart as I am? Do you know the latest language? And I resent that because I've actually seen lives lost because of it. So you have a radiologist who refers to inflammatory stranding around in the right paracolic gutter. They can't bring themselves to say that the patient has appendicitis. They can't say normal appendix. They have to say inflammatory stranding, which is a marker for the inflammation around an appendix. It probably means appendicitis. But do we have to guess? Can't you just say so? Hit me over the head. Dumb it down. And I know that expression from, as I'm sure you do, from our journalistic pursuits, but it could be just as useful in healthcare. And studies show that physicians are awful communicators with patients. Patients walk out of doctors' offices knowing no more than about a third of what the doctor said, what they wanted them to know. And communication is clearly important if we're going to empower patients.
You're listening to Dr. Brian Goldman. He's an emergency room physician at Mount Sinai Hospital in Toronto, Ontario. He also hosts a popular radio show called White Coat, Black Art. His most recent book is The Secret Language of Doctors, Cracking the Code of Hospital Slang.
Coming up, we'll hear about a conversation between a doctor and a patient that's full of opportunities for misunderstanding.
A negative report can mean nothing is wrong. What other terms can be confusing?
How does slang affect patient safety?
What should patients learn from Dr. Goldman's project?
Find out about open notes and how they could be helpful to you.
You're listening to The People's Pharmacy with Joe and Terry Graydon. Thanks for listening to this podcast of The People's Pharmacy. If you like it, why not rate or review it in the iTunes store? We'd appreciate it.
Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Red X Industries, makers of utterly smooth foot cream with shea butter, helping dry, cracked feet feel soft and smooth. 800-345-7339. Online at uttercream.com.
To order a CD of today's show or any People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1004. That number again, 800-732-2334. 2334 online at peoplespharmacy.com.
We're breaking down barriers to communication, giving you the inside scoop on the special language used in hospitals among doctors, nurses, and other healthcare personnel.
Our guest is Dr. Brian Goldman, an emergency physician at Mount Sinai Hospital in Toronto. He's host of the radio show White Coat, Black Art. He's an outspoken medical journalist whose previous book was The Night Shift, Real Life in the Heart of the ER. His new book is The Secret Language of Doctors, Cracking the Code of Hospital Slang.
Dr. Goldman, we found a recent piece in the Washington Post. I think it actually originally came from the Consumer Reports. And here is a conversation between a doctor and a patient. The notes that the patient had taken during a conversation with her cardiologist read, "Your echocardiogram was unremarkable. The ejection fraction was 68%. There was no LVH. All of your laboratory tests were negative. I'll send a note to your doctor." It sounds like she took extremely good notes. And this is wonderful news, actually. But how would you tell? Unremarkable, negative, and no LVH. What the heck was this cardiologist talking about?
Well, let's start with an ejection fraction of 68. I think anything over 60% is pretty good. No LVH, that says no left ventricular hypertrophy, so the heart muscle's not thickened. I think that if I were a patient, I would want to know, what does that mean? You know, what's your interpretation of that? I love the phrase or the word unremarkable. Unremarkable, it's jargon. But I think it's also slang, and there's a slangification of technical terms. Unremarkable means, on the one hand, it means it's not abnormal, but there's a hedginess to it, as if the doctor's saying, I'm not saying that the patient's completely normal or doesn't have a disease, but that somehow this echocardiogram is not contributing to my understanding of what's wrong with the patient. I think that's what it means. To some physicians, unremarkable means it wouldn't get me out of bed in the morning. It's not going to get me excited. There's nothing exciting about this, because pathological stuff like, heart muscles, ejection fractions of 15% where I can do a transplant, that's a lot more exciting than something that's unremarkable.
But what's so interesting about these words is that while for a physician this is all good news, a patient who is told, this is unremarkable.
It's negative.
And it's negative. Your laboratory tests were negative. It's like, whoa, really?
What's wrong with me, doctor? Am I going to live?
And it reminds me of the woman who saw her doctor's notes, your breasts are grossly symmetrical. And she thought, what? The doctor's calling my breasts gross. What's wrong with me? And it's like, the doctor was just saying, everything's fine. Don't worry about it. But, when we see these words, they just freak us out.
Yes, they do. And another one of my favorites, and this is actually a malapropism. When you come back, when you order a CT scan because a patient's having headaches, and then you come back and you want to tell them that the CT scan is normal, except you tell them that the CT scan of the head, looking for a brain tumor or a hemorrhage, that the CT scan was negative. Well, basically what you said is that the person doesn't have a brain in their head. So I would be very,
right, not what you want to say.
I would be insulted, I think, if somebody said that to me. But it shows you the gap between the language that we have ourselves. I think that's what you're getting at, and the language that patients have. And so, I think it's certainly incumbent upon health professionals to take courses in communication, but more important, to be empathetic. Much of the secret language, the slang that's used, betrays or belies a certain lack of empathy, and by that I mean the inability to put ourselves in the place of our patients. And often, the best way to get that appreciation, to gain that appreciation, is to be a patient yourself or the loved one of a patient. In my case, the middle-aged son of two aging and frail parents who passed away, who were admitted to hospital 13 times over a 3 or 4 year period. So I got to know the inside of a hospital from that perspective very well. But the point is, if you are empathetic to patients, you might be thinking, I wonder how this is sounding as I say, grossly symmetrical breasts. And I think a lot of us in healthcare these days are just too wrapped up in our own heads. Perhaps we're worried. We're worried about what our fellow physicians and other healthcare providers think of us. We're worried about being sued. We're worried that patients are going to take more time than we have. And all of that speaks to us being worried about ourselves. And it's very hard to be empathetic if you're not thinking about how worried the patient is.
How does this argot affect patient safety? I know that this is a topic that you are very passionate about.
Yeah, I'm extremely passionate about patient safety, and the slang affects patient safety. If you dehumanize psychiatric patients with slang, you may be looking at the psychiatric symptoms that they have and ignoring their diabetes or their cancer. And many studies, as I've explained in the book, show that psychiatric patients are often seen only for their psychiatric symptoms, and so they are more likely to have their cancers missed. They're less likely to get aggressive treatment for cancer or for diabetes or for heart disease, and they die at a younger age, not just because they're more likely to harm themselves and kill themselves, but also because they suffer diseases that aren't properly diagnosed and treated in time. Morbidly or dangerously obese patients, I think that we're in the very, very early stages of treating them properly, inventing the equipment and developing the skill to treat them properly. And because we have tended to use weight prejudice as the last vestige of acceptable, tolerable, I think it's unacceptable, but tolerable prejudice towards patients in the hospital, we are more likely to blame patients who are obese instead of treating their illnesses. And, fortunately, there are surgeons and physicians who are trying to find better ways of treating them. So their lives hang in the balance because of that. When we do something called blame storming, that's slang for finding the weakest member of the hospital team to blame for a medical mishap. We are not doing a root causes analysis, which means we are not sharing information about medical mistakes. We're not coming clean with the fact that people are making mistakes all the time. We're not learning from those mistakes. And as a result, the system isn't as safe as it could be.
Well, you talk a little bit about the slang police and, this idea of punishing doctors for using this hidden curriculum of medicine. What would be a better solution? What are your recommendations?
My recommendation with slang is that, yes, if you hear overt pejorative slang, to, first of all, model good behavior as a leader, as a mentor, but also to pull people aside gently and say, did you realize that that's pejorative? But beyond that, anger is insufficient. Anger must be followed by understanding in the culture of medicine. So I would say, where's that coming from? I would prick my ears whenever I hear slang. I'm always wondering, where's that coming from? What are the issues that you have? Because I would say sometimes when people use slang, it's because they're frustrated about something. And maybe it's because the bariatric or the special stretcher for dangerously obese patients is being kept locked in a cupboard, or we need 3 of them and we've only got 1. And I know a colleague who herniated a disc in her neck because she tried to lift a patient without proper equipment, a proper lift. And so I would say, good, tell me about that, because we need to champion making those changes. And I think that the danger of calling out slang and naming and blaming and shaming, much as we've seen happen with medical mistakes, is that all it does is push that slang underground. People don't write it, so they speak it. And if they think that you shouldn't speak it to certain people, then they'll make doubly or triply sure that the person that they say it to is somebody they can trust with their innermost feelings. And all that does is push the slang underground without addressing the issues that the slang symbolizes. And I think it's a lost opportunity to do things to fix the culture of modern medicine.
Now, have you coined any of your own slangs?
I thought I coined the term dyscopia. You've heard dis is a prefix for difficulty. So dysuria is difficulty urinating. It's a symptom of a urinary tract infection. Dyspnea is difficulty breathing, so shortness of breath. And so dyscopia refers to somebody who's anxious and can't cope. And I think I invented that term. My favorite bit of slang that I've ever heard was given to me by an obstetrician. It is a C-section consent form. Another ironic bit of slang, cesarean section consent form. And it is slang used by obstetricians for a multi-page birth plan. And first of all, a birth plan is an oxymoron because you can't plan everything that's going to happen with a birth. This is a list of wishes and hopes and dreams. So multi-page means the more detailed the plan. I want a lotus birth. I want this music followed by that music. I want this dancing going on and this singing going on, and no epidural, natural childbirth. I want no oxytocin. I want this. I want that. The last thing that would ever appear on a multi-page birth plan would be a consent for a cesarean section. And it's wicked. It's kind of interesting, but it speaks to two things. It speaks to the fact that you can't plan, and sometimes the best laid plans change in a hurry, and a cesarean section becomes necessary to save the life of the baby, and maybe the mother's in a lot of distress as well. But I think there's a bit of schadenfreude there. Look, I had to endure this multi-page birth plan, and now they're going to get what they didn't want, which is a cesarean section. So I think it's a little bit of a release of hostility, and maybe it speaks to that lack of communication sometimes between obstetricians and their clients.
Dr. Goldman, what can patients and family learn about the secret language of doctors? What is the takeaway message you'd like people to appreciate?
The takeaway message from the secret language of doctors is know that people like me are thinking things, and sometimes one day your life may depend on it, or your loved ones. You may hear slang. You may hear, for instance, FUBA, found on orthopedics barely alive. That is an internist way of saying that the orthopedic surgeons don't know how to take care of people who have internal medicine problems like heart attacks, and may put their patient in heart failure without knowing it and without being able to treat it. And so hear the language, know that it exists, and if you ever hear it and you don't know what it means, ask your health care provider, what did that mean, and hope for an honest answer, and use it as an opportunity to gain greater understanding of the people looking after you and your loved ones, their needs, their frustrations, and make sure they're doing the best job they can, and where change needs to be lobbied for and made, help to make it, help to drive it.
Dr. Goldman, there is a movement in the U.S., something called open notes. And basically what it means is that doctors' clinic notes, what they write into the medical history on that patient, will become available to the patient. So it's not just a summary, it's not just lab results, it's everything. And there are a lot of patients who really look forward to this evolution, this revolution, and there are many doctors who are in favor of it as well. But it really means that doctors are going to have to change the way in which they write their clinic notes, the way in which they communicate with each other, because now that information is going to be shared with patients. Your thoughts?
Well, Joe, you're absolutely right. But I can also tell you that as part of that movement, there have been experiments in which, in New York City, if I'm not mistaken, in which psychiatrists, that there are now open psychiatric notes. And what's happened, the psychiatrist sees the patient, writes the notes, and then they review the notes together. No question, you can't put pejorative information there, but it does force the psychiatrist to be really clear about what they mean and what they want to say. And so far, the results have been that the notes have been fairly complete. They've not been edited or changed in a meaningful way. And patients, in some cases, they might have questions about some of the things that are being written about them because we don't always have perfect insight into our own behavior or into the hidden motivations for our own behavior, but ultimately the patient satisfaction in that open note kind of situation in a psychiatrist's office was fairly positive. So if it could be positive there, frankly, it can be positive anywhere. And you know, when I wrote my book, I found that there was a relative lack of slang used by psychiatrists for their patients. A little bit among psychiatric nurses who work in the emergency department, but not on the wards. And I think they've gotten the message from early on not to say pejorative things about patients. And I think that other people, emerged physicians, perhaps others, have been a little bit slow to get that message. So open notes for them will definitely mean eradicating some of the pejorative language that they write. And I don't think there's anything wrong with me writing notes today, thinking in my mind, I wonder what my patient would think if they could read this.
Dr. Brian Goldman, thank you so much for talking with us on the People's Pharmacy today.
It's been a great pleasure.
You've been listening to Dr. Brian Goldman, an emergency physician at Mount Sinai Hospital in Toronto. He's host of the radio show White Coat, Black Art on CBC Radio 1. He's an outspoken medical journalist whose previous book was The Night Shift, Real Life in the Heart of the ER. His new book is The Secret Language of Doctors, Cracking the Code of Hospital Slang.
You know, when it comes to open notes, there's a recent study that was published in the Joint Commission Journal on Quality and Patient Safety. It reviewed 5 years of shared notes involving more than 2,000 patients and 100 physicians at Beth Israel Deaconess Medical Center in Boston. According to the researchers, patients who had access to their doctor's clinical notes caught medication errors, reminded their doctors about next steps, and were much more likely to participate actively in their own health care.
Open Notes has spread to the Cleveland Clinic, Geisinger Health System, the Mayo Clinic, and 9 hospitals in the Northwest. To learn more about Open Notes and this revolutionary experiment in doctor-patient communication, we have a link from today's show at peoplespharmacy.com.
Lynn Siegel produced today's show. Al Wodarski engineered it. Dave Grayton edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
To order a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1004. That number again, 800-732-2334. On the web at peoplespharmacy.com.
When you visit our site, you can check out prescription drugs, herbal medicines, and home remedies. And you can share your own experience and thoughts on today's show. What do you think about the open notes concept? We'd love to hear about your perspective, whether you're a patient or a healthcare professional.
At our website, you can also sign up for our free online newsletter or the free podcast of the show. You'll never miss another People's Pharmacy program again. You can also share it with a friend. It's all there at peoplespharmacy.com. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you very much for listening. And please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to the People's Pharmacy.